Assalamualaikum warahmatullahi wabarakatuh. Good evening, Professor Morgan, Professor Angus. My name is Nabila. I'm a resident from the Community Ophthalmology Division, Ophthalmology Department, Faculty of Medicine, Universitas Indonesia. And I would like to present our presentation that is entitled General Practitioner as a Champion in Diabetic Retinopathy Screening in Jakarta. So, world diabetes mellitus, the prevalence in 2019 was 463 million, with the prediction that it would reach 578 million in 2030 and 700 million in 2045. This predict an increment in 51% from 2019 to 2045. And in 2019, a diabetes mellitus caused direct death for 4.2 million, with 50% it is caused by the cardiovascular disease. And there are several risks in patients with type 2 diabetes mellitus. And there's also death caused by hypoglycemia in type 2 diabetes mellitus patient, with 19.5% causing death. Unfortunately, diabetes mellitus often goes undiagnosed, and in countries with high population, this often happens. Even in 2019, Indonesia ranked fifth for the countries with undiagnosed diabetes mellitus. The prevalence number of diabetes mellitus in Indonesia, according to Health Ministry studies in 2018, was 2%, and Jakarta has the highest number among the provinces. While diabetic retinopathy in Indonesia has the prevalence of 18% in Jakarta, and research by Sasongko et al. In 2017 found 43% of diabetes mellitus patients experience diabetes retinopathy, with a proportion of mild NPDR 9%, while the highest percentage, 12%, is PDR, with 26 among them have the prevalence of vision-threatening diabetic retinopathy. Therefore, integrated health screening is necessary, and the best way is to integrate the primary healthcare service. And the WHO has a short guidance for diabetic retinopathy screening that is aimed for developed countries, in which the program is integrated with other services. In developing countries such as Indonesia, the proposal is to integrate the screening program to primary healthcare services. Here in Indonesia, we have an integrated healthcare system. For productive and elderly group age, we have chronic disease management program, or as we call program penyakit kronis, abbreviated as PROLANIS, that is aimed to improve the quality of life of people with chronic diseases, in particular diabetes and hypertension, with monthly check for blood sugar and blood pressure. Diabetic service in the society is also supported by the local authorities, especially in Jakarta. We have local policy from the head of health program. We have the program that is called Pelayanan Terpadu Penyakit Tidak Menular, abbreviated as Pandu PTM, to do routine checkup, including eye screening, encouraging primary and secondary healthcare to put efforts into promotive and preventive measures. Early detection of complications associated with diabetes mellitus and hypertension is instructed to be conducted annually, including eye examination. How to do so? So the proposed integrated system is we train the general practitioner and nurse to do the screening, and then we made a screening model that merging doctors and nurses as the practitioner with artificial intelligence or AI. We asked the GPs and nurses to perform fundus photography and grading of the diabetic retinopathy by the AI. So this is the program and this is the situation of diabetic retinopathy screening training in Jakarta. This is given to the general practitioner and the nurse. And how did we do? The training was conducted in one day with the flipped class method, which include lectures, demonstration of videos, and clinical practice with supervision. After that, the GP and nurses were also supervised when examining diabetic patient for 1 week to do real setting screening. And the module include the basic eye anatomy and physiology, how to perform visual acuity tests, how to examine the anterior segment of the eye, including cataract identification, and how to perform fundoscopy. And this is the module book. The result, we have diabetic retinopathy screening flow. That first, we have data input, invitation of patient to attend screening program, and next, thorough eye examination in primary healthcare, taking fundus image, then do grading. The grading was based on ICDR with automated software and manual by vitreoretinal surgeon. Patients who are included in the referral criteria will be referred to ophthalmologists, and for the follow-up, education for patient to do regular eye checkup or referral process for the patient who need it. And this is the result of the pilot project conducted in 2 primary healthcare in Jakarta. We can see that there's 69% of patient or 76% of eye that do not have diabetic retinopathy, while 1.1% patient have severe NPDR, 0.7% have PDR, and 17% were ungradable. And this is the number of patients that were given topical mydriaticum. We instill in 56% of patients. And based on the paper by Guo T et al., the principles of fundus photography grading in the study include 3 aspects, which are position, clarity, and artifact, with the grading system of good, adequate, and poor. The good position is defined as the image that have the distance of less than 1 disc diameter between optic disc or macula center and the image center. Next is clarity. Good clarity can visualize all anatomical structures and details, while adequate some are blurred but acceptable, and poor is when the anatomical structures and details are very blurred and unrecognizable. Artifact is graded as good when the readable region cover 100% of whole image, adequate cover more than 80%, while poor less than 80%. And for the overall score, good is when the 3 sub-items are good, and poor when one of the 3 sub-items is poor. And this is the fundus photography result. Most of them are in good position, while older patient may be challenging to position correctly, leading to poor position. And for the clarity, most of them are good and adequate, while other conditions, including cataract, can lead to poor clarity, as with infrequent mydriatic use. And for the artifact, there's insufficient space for eye examination that may lead to poor artifact interfering with the final fundus image. And this is the condition of fundus examination in the primary healthcare, where The primary healthcare location does not have a dedicated room for the examination. So here we can see that we employ a dense and entirely black cloth to create a darkened space. And how does the GPs and the nurses think about the DR screening and primary healthcare? Most of them say that the program is beneficial for them as they are more aware and more confident to examine patients with eye problems. As a conclusion, the image quality of the final fundus image taken by trained GPs was overall good, which can be a good start for implementing automated grading using AI. Using mydriatic drops for fundus examination should be considered in screening protocols, especially in complicated cases, and further study on feasibility of implementation of a DR screening program is needed. Thank you.
Yes, thank you, Dr. Nabila, for your presentation. I think it's our pilot project, regarding the model of the DR screening program in Jakarta. Before we go to Prof. Angus, maybe I would like to greet everyone who's coming into our discussion this evening. Good morning, Prof. Morgan. Good morning to all the professor. Good evening to Prof. Angus also, and to all the professor and doctors, residents, and fellow who participate in this session. So this evening we are very, very grateful for having Professor Angus Turner this evening, because we know that Prof. Angus is very well known on his work. Yeah. Prof. Angus Turner is the founder and director of Lions Outback Vision. It's a very well known institution in Australia, and I think he has a specific interest in providing a high quality health services, especially for the Western Australia remote communities. And I believe that his phenomenal project is the Lions Outback Vision Fan, yeah, Prof, that serve remote population of especially for Western Australia communities. And his innovations, his innovation in providing eye health services and his specific commitment to rural and remote communities has been widely recognized with several prestigious awards. So we are very grateful for having Prof. Angus Turner this evening. And we welcome Prof. Angus Turner to give a lecture tonight. Please, Prof, time is yours.
Thank you very much. That's a very kind introduction, Yeni, and it's good to see you here. And it was really lovely to hear the description of a program and pilot project happening at the moment. Thanks, Nabila, because I will be discussing some similar information. Now, I just wanted to share a screen, so let's see if I can get this to work. Can you guys see this first page?
Yes, that's good, Angus.
Lovely. So I'm in a very remote part of Western Australia. I've just actually flown in very recently. We got quite delayed in a thunderstorm. And this is a red road just out of the town where I live. It's the color of the dust. But at the moment, it's all mud because it's the wet season coming. And as you've heard, Lions Outback Vision is a part of the Lions Eye Institute, which has been around for 40 years. And Professor Morgan, involved this evening, has been highly involved with the research and as the managing director. And so Lions Outback Vision is really interested in the outback, the regions that are far away from Perth. And it's quite hard to imagine some of these distances, but Western Australia, where we are based, is sort of a huge land mass of 2.5 million square kilometers. And there's actually only 2.5 million people, but most of them all live down near Perth. So there's not many people, but where they are scattered far away, there might be 2,000 or 3,000 kilometers away from a place where there's tertiary eye care. So over the years, we've established a network of outreach visits, and halfway up that map, you can see some dotted lines. I've just flown this evening from Karratha up to Broome, and it's a beautiful country to cover, but many of the hospitals were lacking in eye equipment. So this big truck carries all the specialist gear one would expect in a ophthalmology clinic for a standard of care, and that is taken all around Western Australia. And it's been going for 8 years now, providing a service for many people to save travel. It's a big truck, meets some of the mining trucks that are out there along the road. And then the other side of it is flying out every month from Broome in a small aeroplane. This is the flight I've just been on, and it was looking about this wet as well. In fact, sometimes the lightning in the background of that photo on the right is a bit nerve-wracking, and the gravel runways are pretty muddy. But this afternoon went well. And we've also had the pleasure of building, with lots of support, a new hub up in Broome that's right close to the airport, and it has accommodation for the staff. There's an optometry clinic, ophthalmology, cafe, research space, and it's been wonderful to live in a regional town 2,000 kilometers away from our home, the Lions Eye Institute. And all the fancy equipment that we can have in that has really made a big difference for the patients up here, for managing their diabetic retinopathy in particular, as we are very fortunate to have a retinal surgeon who has all the equipment in the theatre to be able to conduct the kind of surgery that's required. And today, in our town of Karratha, there was a patient with bilateral proliferative diabetic retinopathy and had a general anesthetic, actually, because she just hasn't been able to cope with the laser at all. And in fact, people are very sensitive to some of the treatments. So she had bilateral PRP and anti-VEGF injections today in Karratha with a head-mounted little fancy portable laser that we were able to take into this hospital. And this is Karratha today, where we were flying from. And fortunately, this dust storm wasn't there today, but this is what I saw last time, which is a ridiculous pile of red dust. And the pilot said, "Oh, that looks like it's over the airport. What are we going to do now?" So it's difficult to land sometimes in the desert. But the thing we rely on for all of our network is actually working very closely with the optometrists. So these are two optometrists as examples of many, where they really have the fantastic equipment. They live in the town and know the patients well. And the specialist has to come in only once a month for a treatment visit. And so my day in Karratha today was all surgical. The skill set that I can offer is actually, as an ophthalmologist, important to make as efficient as possible, because we have to cover a population that's very big and should actually have 10 ophthalmologists to meet the need if it's the same as the Australian average. But we don't have those workforce opportunities. So the optometrists and the ophthalmologists try not to duplicate, and we turn up for a visit and it's very efficient and everything's been prepared beforehand by Alex here on the left and Margie on the right. I've been working for many years in regional towns, and Aboriginal health workers are able to really be equipped with fancy equipment too. That's very automated these days and can enable patients to be assessed, and we can view all the images remotely from both the vision van and the regional clinics on the cloud-based viewing platforms. So over the years, just publishing about telehealth, we see that it reduces the waiting times for the surgery. It's much more accessible for Aboriginal patients. There's very high patient satisfaction, and the outcomes are equal or better than normal visits. And all of these things have been shown in various studies over the years. So something that we do slightly differently in Australia is we do take the time to talk to the patient on the video, and run through the consent for the surgery with the optometrist. And that enables the patient to have already met us when they turn up for surgery, and we can talk to them and they remember the video consultation where we've gone through the risks, benefits, and the lens choices that they may have, and have explained what the process is going to be like. So given the topic tonight, I'm actually going to just shift slightly and finish my talk with a little discussion about some recent research we've done, and in the context to explain an audit just in the Kimberley, which is the top part of the West Australia, which is the region I'm living in at the moment. In the last 3 years, we've seen many patients who have diabetes. In fact, you showed some prevalence images there of 18% in Jakarta for adults, but we have 30% of our Aboriginal patients have diabetes. And of the 2,222 diabetics, we were trying to see which stream or which service actually saw them in the last year. And what happened in the Kimberley was that ophthalmology saw a big chunk of the patients because they're being treated with injections or laser. Optometry saw a large portion of outreach visits. You can see there that there were nearly 1,000 of the patients, 934 patients who only saw optometry. But the bit that really is not working very well is the same in many parts of the world, is the really sensible, obvious solution, which you've just been discussing this evening, which is the GP and the nurse in primary care, where the patient is already receiving chronic disease management. That's the place that we should be doing our screening. And yet, for some reason, we have only 226 patients, and yet we've got many cameras. Most of them are sitting in the cupboard and no one wants to use them. So our last year, we've had a really interesting project where we tried to look at why are the photographs not being taken? And some of it's to do with the pressure of the priorities. So mental health, cardiovascular disease, other things take up the GP's time. But some of it's just a few technical glitches that people are having. And I'm sure you've come across these in your own programs. But I looked at the cameras that are around, and this is what we have, similar probably to some of your cameras. There's a joystick, there's lots of buttons. Even this photograph's out of focus, but the whole thing is an old-fashioned camera, which has cords that are going to some computer. Then we've got to take a USB stick and try and send it to some email. And a few weeks later, if they're lucky, they get a grade. And it's a very unsatisfactory process because 20% of our photos aren't even good enough. The photos are, the patient doesn't know what's going on, and the doctor, GP, has no clue either. So look at the cameras around at the moment. These are automated and much better quality. So we've trialed these cameras in different clinics. And we've also been working with Google over the last 5 years to validate an algorithm that they've developed called ARDA, Automated Retinal Disease Assessment. And it's been validated for Aboriginal people in several papers over the last couple of years. And we had an opportunity to set up a prospective head-to-head trial where we could actually put this to the test against some other AI tools that have become available on the market. So the Google one is not approved for use in Australia, but the other ones are. So we tested them on various cameras, and there was a clear winner, actually. So I'll tell you the story here. We tried a region that has very poor outcomes for retinal screening. About 20% of the patients are actually getting screened according to the recommendations. So we're missing 4 out of 5 patients. And obviously the patients end up in theatre like they did today with me. So we did a little project, prospective, had to consent patients to this AI model. 157 patients gave the research consent, and the majority were Aboriginal people. We took a little van around with Starlink and a few other cool things in there to help us get the job done. And the operator was actually a non-eye health professional, a technician, had never done ophthalmology, optometry, and was using the camera. We evaluated with the patients, and they were very happy with the use of the AI. They were quite amazed by the technology. because for the first time they had an answer on the spot. And here's some results. This table's a bit busy, but you can see we trialed 3 AI tools, Google, one Therona from the Netherlands, and Iris from Singapore. And look at the sensitivity. So the Google sensitivity was fantastic. For a screening program, it was able to pick up every case. It was actually better than the retinal specialists in our previous validation tests. We had really high level of gradable images that we've not had with previous AI of 97.4%. So it's a very useful tool. And this project actually took a lot of partnerships. We had heaps of people on the ground helping us enormously to get to the patients. We had some funding, support, research partners, and technology partners donating equipment. So just to finish off on this point, we're very fortunate now that Google has actually acknowledged that their product is needing to be used in Australia. And so they've actually decided to enable us to use it and get regulatory approval. And that's something we're in the process of conducting at the moment. And I'm very confident that within 6 months, we'll have the software to support the algorithm and provide this in primary care. So the camera is more automatic and has less technical glitches. The images can be graded on the spot with the AI, and then we can follow through with our services with the treatment for those patients that need it. But something that came along during our last year of working with some partners was some very exciting research that I think is actually going to take this to the GP in a new way. And the nurses and the GPs will get excited because they're not very excited about eyeballs, unfortunately. And we've had great trouble trying to promote the use of any camera. But now that the partners that we were working with have published an amazing article in Nature last year, where the image of the retina is actually defining very accurately other cardiovascular, renal, neurological diseases. And that's because for us, it makes sense. We've got arteries, veins, and a nerve, and the pattern recognition of AI is phenomenal. So those are a non-invasive biopsy of what's going on in the body. And if we can value add with this open source foundation model, fine tune it in our own population quite easily with 1,000 patients that we've just got ethics approval to follow through for their hospital records for cardiovascular events, for example, suddenly we've got a tool that the GPs will say, oh, now we're talking, because that's the biggest killer. And really, the patients really need a hand, especially 20 to 40-year-old male, obese, cholesterol, other things going wrong, and they don't quite fit the traditional risk scores and profiles, such as the Framingham, database and other things that are not really fitting treatment plans. And so I think oculomics, as this has been coined, is a really helpful addition to the risk profile for patients. So here was the paper, it's worth looking up. And the second author there, Mark Chia, was with us in Outback Vision for a few years doing a PhD, and he's actually just moved now to Melbourne to start his ophthalmology training. So we're hoping to be able to continue this work over the next year. And then we can imagine that a camera like this, so simple and portable even, can actually help that GP or nurse get an instant ophthalmic diagnosis, but also a whole body health snapshot. And then I think we're really looking for an exciting future for our eye photographs. So thank you very much for listening in today, and I'll be happy to hear about any discussion.
Yeah. Thank you, Prof. Angus, for a very excellent presentation, sharing your work, your project. I believe that it's been a success, yeah, for especially for serving the remote or the population that underserved, yeah. So So when I see your slide, especially the first slide photos, yeah, I think that we have the same demographic challenge, yeah. Not in Jakarta, of course, but some part of Indonesia still have the same problem about the access to the qualified health eye health services. Yeah. So maybe I will now will look into the chat box. Is there any questions?
I see Prof.
Yeah.
Morgan.
I think Prof. Morgan's
Um,
having a question. What kind of camera do you use, and
Okay, well, that's it's a helpful.
using the AI, Google AI, the ARDA?
Yeah, so the Google AI has been developed on a couple of different cameras, but the one that we have been using is Topcon, and so that is the one that we did the analysis on in this study. It's very easy to use. It's actually been around for a little while.
Yeah.
There is another camera that we have been using, which is portable and has, out of all the portable ones we've used over the years, had much better gradability, and it's built by Optomed, which is Finnish, and in Finland. So they came over to Broome actually and gave us a couple of these cameras. And Topcon has been a research partner as well and given us many cameras in the past. So what we realize is that when the ARDA is transferred to us to develop further, we will test our database of portable handheld photos as well, because at the moment that hasn't been part of our research.
Okay, so is the ARDA is a device-based or a cloud-based AI?
It's cloud-based, but one of the challenges we have in Australia is the rules about sending our photographs overseas. So we are now having to put the tool in our own server in Western Australia for patient data sovereignty.
Yeah. It's the same regulation. I think it's the same policy here in Indonesia about the sending your data outside the country. So I think it's the same. Yeah. And also, I think we're using the Topcon also. We are supported by Topcon for our project, but we're using the former type, the NY 400, and I see in your project you're using the NY 500, right?
Yeah, and also the Maestro, which is the one that has the OCT as well. But that's because many of the places that we work have injection clinics once a month. So the screening happens and then we fly in for the injection clinic.
Yeah, good. So thank you, Prof. Angus. The next question from Dr. Dio. Dr. Dio is a GP from Pasar Rebo Primary Healthcare. Will the Google ARDA will be released worldwide, or is it only will be used in this project?
That's a really good question, and it's something that I have been actually personally challenging Google on, because they were interested in this about more than 5 years ago, but then the priorities of a global giant move on, and I think Gen AI and other stuff is a bit more interesting at the moment. So these kind of projects are research and then they get shelved, and I think the research partners at the moment have actually navigated this project to be transferred. So, for example, Aravind Hospital in India, we've been collaborating with them, and a doctor and network in Thailand as well.
Yeah. So
it's been regionally focused at the moment, and partly because everyone's got its own regulatory approval, and life's pretty complicated, and Google is not interested in spending the time to navigate all those things. They've got other priorities.
Okay. So, from the three AI software, which one give the best validity as an index tools in your population? I see that you're using ARDA, you're using Red Cat, and also what the other one?
Selena Plus or Iris.
Yeah, Selena from
so,
Singapore.
so look, RetCAD in this one performed pretty well as well. We've used the RetCAD in other papers before, and it wasn't actually as good as this recent one. The RetCAD for us was a slightly less useful output. It didn't tell the GP when to refer. It was all sorts of probabilities and color maps.
Yeah.
And whereas the Google ARDA was just more than mild, refer, or severe disease, vision threatening. So it was more useful categories for the referrer.
For the GPs in the primary care, it's more useful for ARDA, because I think that the Red Cat is give you a score, right?
And didn't mean anything. So we kept changing the thresholds. That's right.
Yeah, threshold. Okay. Yeah. But I think the message learned is when we are using the AI, it should be tested first, in your own population, right?
So there's two bits. You've got to validate in your own population. It's getting easier and easier to do that. And Prof Morgan has also asked about the center-view DRS. Yes, we've been using a camera as well, the DRS Plus and DRS in a lot of our photographs because they're so easy to use. Once again, we haven't tested the ARDA on those ones. So I'm looking forward to just getting hold of this algorithm so we can actually work on a few new projects and be agnostic to the camera and agnostic to where people want to work with it.
Yeah, okay. Thank you, Prof. So the next question will be from Dr. Firna, who raised her hand. Please, Dr. Firna.
Thank you, Dr. Yeni.
Yes.
Thank you. Thank you, Angus, for a very excellent presentation. I really enjoy a lot. I'm sorry I'm off cam because I'm still driving on my way home. But it's very interesting topic. So I wonder, I want to ask about the glaucoma in your outreach program, Prof. How is manage your patient with glaucoma? Because I know that because of you mentioned about the 50% diabetes incidence, right? So could be maybe neovascular glaucoma could be high there. So
we have
you manage the glaucoma in your outreach program? Thank you.
Well, fortunately, Professor Morgan visits Broome, and then I send the patients down to him.
So I should we go to the center?
Yeah, so we tend to struggle to do much glaucoma surgery when it comes to stents and tubes. Up in Broome, we recently did put in some stents in the clinic hospital here, but it's not actually an area of my expertise, and my colleagues have been learning to do it recently. But in general, we've had to send people down to Perth. And fortunately, with the VR service here, we've been able to keep a lot of it at bay with the injections and laser.
Yeah.
Thank you, Prof.
So I think it's a very interesting question, Dr. Firna. I come up with the question for Prof. Angus. How do you finance this project? Is it come from the government, from the NGO, or how is it to make it more sustainable? Sustainable is a very challenging issue.
It's very challenging. It comes from everyone that will put money into the hat. So we're a not-for-profit charity through the Lions Eye Institute, which is a great opportunity to therefore have philanthropy. So about a third of our work has been donated by people and relationships with partners. And then 1/3 of our work capital has come from this Commonwealth government, which is Canberra, the middle of Australia. So that's the federal government. And then the actual service delivery is, we've had to say to the state government, you can't afford to do good ophthalmology on your own. So why don't we all get together and have the federal government, the state government, and the philanthropists, and all three chip and we'll have a really world-class service.
Yeah.
And that's involved way too many meetings and all of that, but it's come together very well.
Yeah. Excellent, Prof. It's been an inspiration for us, so we can get the same result with your project. Okay, I would like to have another question from Prof. Morgan. Angus, have you used any confocal cameras with
I
the
think
Google AI?
Angus answered
Yes,
that question.
I did touch on that
Yeah.
one, which is just to say, yes, we do use these cameras, but we haven't used the AI with the Google, no. And there's another question here saying, I'm curious on how the fundoscopy generates other organ information. Well, look, that's the mystery to me as well, is like, how does that fundus photograph say whether someone's a male or a female or a smoker or what age they are? But the more we look at that photograph with training data sets and self-supervised learning and huge models, the more the photograph reveals. And so that's why it's a very exciting area to see what we can contribute to whole body healthcare through an eye photo and get more traction that way.
Yeah. Yeah, that's the magic of AI, Prof.
Yeah.
But actually, we have experience. We developed the one AI software with its algorithm by using the fundus image, and then we're putting some clinical findings like the H1 HA HbA1c, and also the other clinical finding like cholesterol and so on. Then we can get the predictor for the risk of cardiovascular complication in diabetes patient. So yeah, I think in the future using AI will open a lot of opportunity for us to give a very comprehensive result, yeah, not only the eye but also in systemic conditions. So
That's
yeah.
right. There's a question here about the training for GPs and nurses, technicians. Look,
Yeah.
the medical school still has ophthalmology, fortunately, where I live. Many places around the world have scrapped ophthalmology, but we teach them how to use a fundoscope, and it doesn't really work for the GP. In our sense, the cameras are so good with a broader, wider view. I think it's worth possibly focusing more on how to use those cameras well. But the other side of it is that our nursing schools also currently lack good ophthalmic training. So there's a push to do more of that. And we, of course, have just started a new optometry school in Western Australia, the university in WA. So we're very excited that technicians, nurses, optometrists are, constantly in training, and something we have to support so that there's the better coverage for access for everyone.
Yeah. Thank you, Prof. And another question is maybe from for Dr. Nabila. Yeah, is there any resistance from the patient when we are going to instill the midriaticum for
Yeah, we don't really often use drops, but when we do, it's because the photo is poor and the patient's willing. So that's another nice thing about the Google AI is it tells you if the photo is good enough and when to dilate.
Yeah.
So for a technician, they can just say, look, it's been advised that you have some drops and here's a pair of free sunglasses. Can you hang around?
So you give the free sunglasses
Yeah.
because of the midriatic effect.
Yeah.
Okay. How about in Jakarta, Dr. Nabila?
Yes, Dr. Yeni. So there are some patients that refuse the topical eye drop because of the effect, the blurring effect, and the glare effect that happen from the midriaticum. some refuse because of that condition, and well, some others are willing to have the effect, and we're having better result for the fundus examination after the installation.
Yeah, definitely.
And as far as we give the midreticum, we didn't see any side effects, yeah,
Oh,
for
no.
the patient. So yeah. Okay, so I think all the question is already answered.
Great. Well, it's been lovely to join you guys. Thanks for such an interesting discussion.
And yeah, Prof. Morgan, do you have something? Oh, we still have one participant who raised his hand. Dr. Ahmad Asraf, please. Do you have any question?
Yeah, thank you, Dr. Yeni. I have two questions. The first one is for Dr. As we know, as you mentioned before, that this program is a pilot project into puskesmas or primary health center. So we know that one of the big challenges is the sustainability of the program. So how you face this problem as for the sustainability, or is it only for the one-time program or the continuing program? That's for Dr. Nabila and for Professor Angus. We are very happy to hear your share experience, as we know also that in our country, the community ophthalmology is very challenging because, as you know, we are still developing country. And in your country, we know that Australia is the developed country. So we are very happy to hear that Australia still have the community program for the people. So this is one of our good news for us. Thank you.
Thank you very much.
Thank you, Dr.
Yeah. Maybe Dr. Nabila first want to answer the question from Dr. Acho.
Okay. Thank you, Dr. Asraf. So, as this is the project for from Dr. Yeni for her PhD. So, I think the challenge is, yes, this is sustainability, but for this condition, we have the Prolanis, or the chronic management program, and in Jakarta, the local authorities already made some regulations for the primary healthcare to do checkups for diabetes patient and hypertensive patients, including blood sugar regular checkup, which include also eye examinations. So as this is recognized by the local authorities, we hope that it will be a sustainable program, and we hope that we can screen as much as diabetes patient, because as we seen from the data from Professor Songko in Yogyakarta, 26% of the diabetic patient have the vision threatening. So this is a really concerning condition for us, and we really hope that it will be a sustainable project. Yes, Dr. Yeni.
Yeah, thank you, Dr. Nabila. Yeah, because our local government in Jakarta, they have a commitment to do the early detection for diabetes complication, including eye. So I think we need to, use this commitment to support the local government by providing the model that can be adopted. I know that the model is still testing whether we are going to use the manual grading or the automated grading, but looking at the demographic profile in Jakarta with the very dense populated, and also I think the internet connection here is very good. The facility is the facility is fair, yeah, good also. So I think we are going to use this opportunity to scaling up our project. But the sustainability, yeah, for the first time, for the pilot project, we are supported by the research grant, but we tend to use the data to advocate the local government. So hopefully that they will be more supportive on continuing this project. Yeah, Prof. Angus, do you have any? Can you answer the question from Dr. Ashraf?
Look, I think thank you for the question, Dr. Ashraf. I think it was to do with your encouragement that developing countries and developed countries, we all need to consider our populations that are marginalized or have unmet need. And so even in a richer country in terms of its city populations, there's some people who are missing out. So, it's important to keep that up. And I'm very encouraged by what I see, what you guys are doing. And I look forward to visiting one day and learning more.
Yeah. Thank you, Prof. I think we are going to learn each other, yeah.
Yeah, for sure. We'll reconnect.
Every projects that we conducted. Okay, because our time is limited, it's off. I think I will give time for Dr. Mita, or yeah.
Yeah, Dr. Yeni, maybe
Yeah.
I will invite everyone to take a photo, and Dr. Miki will assist us.
Thank you, Dr. Nita. Good evening, everyone. Thank you for joining our Australian Indonesian joint lecture series today. I would like for everyone to open up your camera as we will conduct our photo session shortly. Okay, I will start taking the picture now. Everyone give us your best smile. 1, 2, 3. Okay, second page. 1, 2, 3. Third page. 1, 2, 3. Fourth page. 1, 2, 3. Fifth page. 1, 2, 3. And the last one. 1, 2, 3. Okay, that will be all. Back to you, Dr. Mita or Dr. Yani. Thank you.
Yeah, thank you, Professor, doctors, Prof. Angus, Prof. Morgan, and all the staff, FKUI staff, and also the residents, fellows. And I think tonight we have more residents from another university. Thank you again, and hope to see you again in next month with our new Australia or another series of Australia Indonesia joint lectures. Thank you. Good night, everyone. Assalamualaikum warahmatullahi wabarakatuh.
Thank
you. Goodbye.
you, everyone.
Thank you, Doctor. Thank you, Prof.
Yeah, thank you.